This is Sean Huang with Psychiatry. If you're a healthcare provider, you've been here before. You're explaining to a patient that the antidepressant you're prescribing isn't just for depression, it's also for the anxiety symptoms. Or you're telling a patient with bipolar depression that the medication you're choosing is an antipsychotic, and you see the confusion and concern in his eyes. We stress the importance of precise diagnoses in psychiatry. But what about drug names? The categories we use every day, antidepressant, antipsychotic, mood stabilizer, are relics from the 1960s. They were created based on what was hoped the drugs did, long before we truly understood their biological mechanisms. And to this day, an understanding of these mechanisms is still incomplete. Decades later, these labels are not just outdated, they're often unhelpful. What's the alternative? For years, experts have suggested naming drugs based on their specific biological mechanisms. The problem? Most psychiatric drugs don't have just one mechanism, they have multiple. This is where a proposal from Dr. Nasir Ghani comes in. He suggests a nomenclature based on a broader range of biological actions, making it more accurate and, most importantly, more useful in clinical practice. Imagine explaining medications in this way. Instead of antidepressant, you say, this is a monoamine agonist. It's used for unipolar depression and anxiety syndromes. Instead of antipsychotic, you could say, this is a dopamine blocker. It treats psychosis and mania. Instead of the vague mood stabilizer, you say, this is a second messenger modifier. Its job is to prevent mood episodes and bipolar disorder. And for anxiety, you'd use GABAergic agonists. Think about the benefits of this clarity. First, it reduces stigma. A patient is much more likely to accept a dopamine blocker for their depression than an antipsychotic. Second, it manages expectations. A patient with bipolar disorder won't fear that a second messenger modifier will numb their emotions, a common fear with the term mood stabilizer. And third, it makes sense. A patient with an anxiety syndrome would not be confused when prescribed a monoamine agonist instead of an antidepressant. The name matches the function. By adopting a more mechanism-based nomenclature, we can empower our patients, reduce stigma, and make our treatment plans clearer. What do you think? Have you struggled with the existing psychiatric drug nomenclature in your practice? Share your thoughts in the comments below. If you found this content informative, please like and subscribe.